Do that now, and welcome back, everybody. And let's get into Academy Business then. So we're going to begin with our report from our co-chairs, from Janet and from Mohammed, into quality and patient safety issues discussed at the academies. Of course, we've got the reports of the chairs, but it's an opportunity for those chairs to bring to our attention anything that might be particularly relevant to directors. So Mohammed or Janet, shall I turn to either of you in the first place, please?
Yeah, I think I'll start because I did the November meeting and then Janet did the December meeting, so that probably works quite well. My apologies that I wasn't able to join in the conversation right at the beginning because I was having a bit of a nightmare commute into the office. But I just wanted to get on record my thanks to Janet as the co-chair for the Quality Patient Safety Academy. It's been absolutely invaluable to having you, Janet, and your input and support's been amazing. So I think I'm going to struggle without you. So we'll try and get some support as appropriate. Okay, so just in terms of the Academy business from 30th of November, I'll say the paper is read, but I wanted to pick out a few things if that was okay. So as you know, we've split the meetings into a learning meeting and an improvement focused meeting. Sorry, an assurance meeting and a learning and improvement focused meeting. And we find that split works pretty well. And we did that on the basis of feedback from exec and staff when we had our away day back in February. In November, we had a discussion around PSERF and the Academy business, and we had a discussion around connecting work around inequality with quality, recognizing that there's an intrinsic link between health inequalities and focus on quality. And we had a good discussion about that, and we linked that to the overall organization strategy around addressing inequality and EDI, and we know that Mel, as our CEO, is the chair of that council as well. So we want to draw those connections more strongly, and we were able to do that. We had a discussion looking at a kind of quality account and improvement priorities, and we looked at the dashboard. We had a really comprehensive discussion around some of our metrics, particularly focusing on any outliers or perceived outliers, and I think that's probably the key word, because there was one particularly around sepsis screening where we weren't doing particularly well on the surface of it. But we had a good discussion with Ray and Paul Southern as well, and I wanted to just put on record my condolences to his family. And Paul was a wonderful colleague and very, very insightful and always kind of proactive in providing his input. At this particular meeting, Paul did contribute to this discussion around sepsis screening. We think that the reason why we were an outlier around sepsis screening on this particular dashboard or something to do with the way that Cerner works and the workflows around Cerner, rather than it being something that we as a trust are falling behind on. And Ray gave us assurance that that in other metrics in terms of outcomes, we weren't performing kind of as an outlier, and that gave us that assurance that there was something perhaps with this metric that wasn't quite working as it should. And we took an action away to go and benchmark ourselves or attempt to benchmark ourselves against other trusts using Cerner Millennium, so we could see how we compared against trust with a similar system where perhaps workflows may be similar. So that was an ongoing action that we're going to follow through. We had a discussion again, perhaps linking and staying connected with Cerner around respect and the respect form. We had an incident around the use of respect form, and we recognize some challenges about embedding respect within the EPR system, and we've got a bit of a work ongoing around that. It may be something that Paul or Karen may want to chip into at the end. As ever, we spent a considerable amount of time looking at maternity and neonatal. We always get an update from Karen and from Sarah, and so we spent some time looking into this and seeking that assurance. We also looked at the kind of HSIB reports, and we were given good assurance from Karen and the team around how we do our learning, that our learning starts, as soon as the incident is logged and recorded, and we're not waiting for the conclusion of reviews. In particular, I think there was some discussion around some particular serious incidents had been passed over to, I think, Liverpool Women's Hospital for a review, and we wanted to get on record, and we had a good discussion about this, that we hadn't waited for that review externally before taking on board the learning, and the learning had happened much earlier. And actually, Karen gave us an assurance that once we'd got the report and external validation and oversight from Liverpool, that actually it matched up with the internal learning we'd already taken on board and we were already implementing. So there was nothing new that had come out from the external review, although that external review took a bit of time. So on paper, it may have looked like we waited a long time for the conclusion of that SI, but actually the learning had happened much earlier, and we were assured by that. Now, we had an update around learning from deaths, mortality review, and the medical examiner service. And actually, Bradford's in a pretty good position in terms of this. We were also made aware of challenges around GP recruitment slower than hoped. And there was a bit of a challenge perhaps around who's responsible for making sure that the medical examiner service is kind of statutory from April 2023, but who's be accountable for embedding this service. And we had a good discussion around that. We, as ever, had a discussion around high-level risks, and we've kind of set out the key risks that we discussed in there. We also found that we just run out of time, and Janet and I have both struggled with this in terms of these sessions are so full of rich discussion and detail that we just don't find that we have enough time to delve into the issues as we'd like, and to do justice to some of the issues. So I'd actually proposed that for the assurance meeting, we extended it by a further half hour. So there's those meetings, the assurance meetings are now 2.5 hours rather than 2 hours. And so that was kind of the November meeting. Perhaps, I'm not sure whether, Max, you want to see if anyone's got any comments on that and then pass over to Janet.
Well, I think we'll go to the December meeting as well then, Mohammed, first. Just offer the opportunity for Janet to bring to our attention anything there, and then we'll open for any questions that may have arisen in either of the chair's reports. So, Janet, please, if there's anything to emphasise.
Yes, I won't overlap. The December meeting was the good thing about the December meeting. I'm going to say something about the process here because I think it's useful that the focus of the meetings have shifted so that we can pay acute attention when it's assurance, and then be much more exploratory and discursive when it's about learning, and that's why the length of the meetings varies somewhat. And I think for me, the December meeting, and thanks for all our colleagues to help contain the agenda, because as we learned in our board away day, you know, we have it very detailed what should be addressed in each meeting, and there is a lot of materials to get through. That said, we were unable to be focused, and I hope the report is also better in terms of explaining the risks in particular of what was on the table on the day and where we might have had deeper conversation, because clearly we don't have deeper conversation, you know, about everything. Sometimes it was just individuals needing clarity. So I think structurally and process wise, I think Mohammed, you've got a better system going forward. So that's one thing I wanted to pull out.
Yeah.
And back to the serious incidents, I think perhaps for the non-executive directors, it is really important for us to have a clearer tracking, because we're coming in and out of it, and it's been agreed that will be clearer, particularly when we're coming up to key dates of which achievements, you know, and milestones should have been met, and those things have been agreed. So Mohammed Zohri mentioned things about risks relevant to the academy on the day, and those were addressed, and hope that's clear for you. And at each meeting, we're blessed, and it's hard work for maternity and neonatal services update, but we are fully appraised and have a huge suite of information, and as you can see from some of the news that Karen's been able to share early in the meeting, you know, we really are on our way, and that has been. And my plea is just to keep that maternity services high on board level until the future, because there's more to be done, and we certainly won't rest on our laurels. So I'm not going to dwell. I thought the report was probably more explanatory than I've managed to achieve in previous meetings, and just open it up for conversation.
That's brilliant. Janet and Mohammed, thank you very much indeed for excellent summaries, actually, of the reports that colleagues will have written, and for you both recognising the benefits you're seeing of the separation of assurance learning and improvement sessions. that's great. So my comments to you both as chairs of the Quality Academy and the way in which you're dealing with that huge amount of work. Thank you. Colleagues, was there anything that arose in the chair's reports that you would wish to raise for discussion, please? Any further queries? And if that's not the case, I'm so pleased to see the medical examiner insight, Mohammed, personally. I think that's going to be really important work in 2023. So great that your academy was able to get good insight on that early. Thank you. Okay, if there's no further comments, we will note the reports. And of course, our chairs remain with us for anything that might arise. But shall we now move to our maternity issues? These are, of course, to note and approve. Now, there are 15 appendices, and I know a lot's asked of us in terms of going through everything that's there. And in the closed board session, there are some additional, more confidential reports that colleagues will have seen there, I think a dozen or so. So there's a lot to read through. I hope people have had the chance to visit those, to see those. But as ever, it's great that we've got Sarah with us as our Director of Midwifery, of course. And as ever, we pay Sarah the courtesy of saying to her, Sarah, is there anything you would wish to bring to our attention? Karen, as I always do, I'll go first to Exec Director and just see whether you wish to orientate directors towards anything before hearing from Sarah.
Thanks. I've notified Sarah that we've already touched on CQC and the MSSP, so we won't cover that again. Sarah's going to touch on stillbirths briefly, but the majority of today's meeting is going to be around the maternity incentive scheme and the sign off of the documents. So a million apologies for the number of documents that you've had sent through. Sarah's pulled together a presentation to go through a synopsis of those. But it is a requirement so that we can go through the gateway for year 4 of the MIS. I'll hand over to Sarah. Thanks.
Thanks, Karen. I'm certainly not being critical of the amount of data that's being shared with directors. It's important. Our challenge is perhaps to get to the key points. Yeah. So, Sarah, great to have you with us again. What would you wish to bring to our attention, please?
Thanks very much, Max. So yeah, as Karen said, I've summarised the November and December papers really briefly in the attached presentation, and then the main focus will be on the maternity incentive scheme. We are required to submit that on by the 2nd of February, and this will hopefully give board enough assurance that supports Mel to be able to add her signature to the sign off the board declaration form. So I'll talk through that process. I did just want to really briefly mention that some of you may have seen the article in the HSJ recently. I think it was about November time, regarding the Embrace report, and Bradford was still highlighted, obviously, as a red dot for stillbirths. It's just to give board that assurance that firstly, that is data from 2 years ago. That's 2020 data. Obviously, our water board conversations have got much more robust in the last in that 2 year period, and I think you've been fully appraised of the amount of stillbirth reduction work that we have been continuing to do, including how we're feeding reducing inequalities into that work now. We have talked about that Embrace report within our core governance meetings. Stillbirth remains very high on our agenda. We've just come to year end, so the January update, but which will go to March board, will have a little bit more information about our end of year position and some of the detail there. So I just wanted to briefly mention that it's still very much a focus for us. So if I could just go to the next slide, please. So briefly, highlights for November and December, and there are a couple of things, as you said, Max, that I just need to ask board to note and approve. So for the November suite of papers, appendices 2, 3 and 4 were around the neonatal medical and nursing action plans and a review paper, and that is an element that's required to demonstrate compliance with Safety Action 4 for the maternity incentive scheme. So it just comes to board for the final nod, but just for assurance that those papers have been through People's Academy with Ray chairing that meeting, and I think we're agreed at that point. So it's just to sign off that last bit. In addition, I just wanted to mention that 90% of all staff groups completed PROMPT, which is our emergency obstetric training. That's a multidisciplinary approach, and also includes neonatal life support. And we'd completed that 90% target by the 4th of December, which makes us again compliant with Safety Action 8 of the Maternity Incentive Scheme. And I think again, as an organisation, that's something we should be really proud of, because throughout the challenges that we've had with staffing, as a post-pandemic issue, we've continued to really focus and make sure that that's something that we do achieve. So we're very pleased with that. For December, there are a number of appendices again. So you'll find some obstetric attendance audits, and that was around demonstrating compliance with Safety Action 4. And essentially there are certain conditions where a consultant obstetrician is required to be present for an intervention or when something's happening. And Carolyn has pulled those together. Plus there are some actions that we will be taking forward with that to improve. And I think one of the main things there is around documentation. So we think that consultants are more present than is actually documented on occasion. So that's been a bit of a decline since we've gone to EPR, and the working together to look at how we can make sure that we're robustly capturing that information. Appendix 5 is a quarterly perinatal mortality review tool report, and you may recall that we do get that on that quarterly basis. And again, that's something that we're required to demonstrate compliance with Safety Action 1. I'll talk about it in more detail shortly. And then finally, you may be now finally relieved to see that we have been able to finally include the maternity dashboard. Now it's a numerical dashboard rather than the run charts that we used to produce. But as you may recall, we've had quite a lot of challenges pulling our information into dashboard format since we went live with Cerner. But we're now in a much better position and have been able to put something that we are happy to present to board now, and will continue to do so. We're hoping that we will get back to displaying it in a more visual way, hopefully over the coming months. One of the things that I did just want to pull out there is that we've had a couple of instances where our one-to-one care in labour has fallen below our 90% target just on 2 occasions, and there were consecutive months. And since the information that you have, we've actually had an increased position for the next month that's due. But what we have done is it's definitely something we're keeping a very close eye on, and we've gone back to our labour ward coordinators, resumed data validation of this, because we think that partly it's about how midwives are entering it into the system rather than it being a true reflection that we're not meeting that target. That will be included on our action plan for the Maternity Incentive Scheme return around that particular element. So if I could just go to the next page, please. So as I've said, Maternity Incentive Scheme, this is year 4 of the scheme, and it's intended to support the delivery of safer maternity care in all acute trusts. We've declared compliance in the previous 3 years, this particular year has been quite a difficult one in the sense that it's been paused and restarted. The deadlines have changed on a couple of occasions, again due to national recognition of acute trust challenges with staffing and post-pandemic issues. The board declaration form must be signed by the chief executive for the trust, and also the accountable lead for commissioning maternity services at the ICS, and there's a submission deadline there. So if we move on to the next slide, please. The board reporting process. So just a bit of a refresh as to how board are appraised of some of the compliance bits throughout the year. So the maternity and neonatal services update paper that you receive on a monthly basis is used as our primary mechanism for updating and appraising you on the progress throughout the year. So for example, things like I've just said, the quarterly PMRT report comes through that paper. Our retain, that's the avoiding term admission reports, also come through there. Staffing papers, etc. So there are a number of things that come through as they arise during the year. Throughout the year, the evidence required to demonstrate compliance is also presented and discussed in a number of other places. So there'll be our internal core governance meetings, of course, but also things like Attain and the perinatal mortality review tool are discussed at joint obstetric and neonatal services meeting, our governance groups, and also with the bi-monthly maternity safety champion meetings where Karen and John will will scrutinise and put challenge to the service representatives there. Workforce papers, for example, are also looked at in other academies, such as People Academy, prior to presentation to the board. So that was just that little bit of background of where you might see things that allows us to get to that compliance position. Just another important note that all of those maternity board papers are also shared with our maternity leads at the ICS, and that's through a monthly maternity oversight meeting. So again, I would say that they're really supportive meetings. It's Jill Paxton tends to chair that in her role as Associate Chief Nurse for Quality within that organisation, and she does come at it with a very supportive approach of actually what can they do to support us if we're having any particular issues. But that level of oversight is discussed robustly on a monthly basis. So we could just go to the next slide, please. So in addition to how it comes through on a regular basis throughout the year, I also then prepare an annual MIS summary, which is the third suite of documents that you've received this time round. That's provided pre-submission and does include additional information, which I appreciate there is quite a lot of. So the biggest thing that you'll have there, and the biggest appendix, was the Saving Babies Lives, which contains all the audits and action plans. Now we are looking at how we can, again, minimise you having to have all that in one go. Unfortunately, this year, again, due to Cerner, some of that detail and data wasn't available until the 11th hour, which is why you've received it in such a lump this time. But we're hoping now we're a bit more settled there, that should improve. So there is also a final assessment of the position of each of the 10 safety actions. Exactly again, this same summary is shared with the ICS maternity leads. We've met with Michelle Turner and Jill Paxton already to go through the initial where we are. There's a meeting on the 26th of January post board to be able to provide her with that final confirmation of completion of any outstanding actions or evidence that will enable her to sign off. And then that will be followed by a meeting with Mel on the 26th, who will be able to complete the board reporting form to enable the CEO submission. And as you will recall, Mel is obviously the accountable officer for both. So to avoid that marking your own homework element, that's why Michelle is signing it off on Mel's behalf for the ICS. So on to the next slide, please. The year 4 position. So we as a service believe that the standards for each of the 10 safety actions have been met, subject to. So board actually acknowledging and approving the final reports that I've just referred to for November and December. And also acknowledging the audits and action plans for the Saving Babies Lives that have been included as the appendices to the Maternity Incentive Scheme overarching paper. There's also one other thing that we just need to make you aware of that will need to be included in the board submission paper, and that is that Safety Action 1 will meet compliance as long as we include some narrative regarding one baby where there's an element of all the babies that died in that period have been recorded. There was one baby who was recorded on the PMRT system, but there's a requirement to complete the surveillance data within 4 weeks, and unfortunately that wasn't completed due to some quite significant mitigation there. This was the baby that was associated with the maternal death. There was some coroner involvement. It made it quite challenging, but NHS Resolution have assured us that they accept that mitigation as long as we allude to it on the final submission paper, which we of course will do. So if we just go on to the next and final slide from me, that's just the overall summary of the year 4 position. So subject to the things that I've just mentioned, we will be able to declare compliance in all of those elements, which are just broken down into the 10 domains there. And I think the last slide is just any questions. And I feel like I've really galloped through that. So
no, it's absolutely fine, Sarah. Thank you very much. I think we could all attest to item 9 of those 10 questions, which was, are the board sufficiently cited? We certainly cannot say that we don't get the data. The challenge, of course, the test for you and Karen is to make sure that you direct us towards the key issues, which you do very well. Thank you, Sarah. That's very much appreciated. I'll pause for any thoughts or questions that might arise. There's two things in my mind. The first is to thank Sarah in advance and Karen for a session that's going to be run on Tuesday, a face-to-face session with Karen, Sarah and other members of the team, open to all non-exec directors and governors. So good on you. That's what we should be doing. We should be opening up and allowing some scrutiny and some discussion and some understanding and insight, which is what it's about really, to our governors and indeed to non-executive colleagues. Sarah, also can I just mention to you that Mohammed and Janet both complimented you and the team for the amount of information provided at the academies, and recognise, it was very articulately put actually, recognise that we know there's still plenty to do. So there's plenty being done and we get that and we commend and applaud that, but there's still plenty to do. Thank you for what you're doing there, Sarah. Okay, so there's a couple of thanks there. Thanks for the session next Tuesday and certainly for the information that you are providing and the leadership you're showing. Colleagues, is there anything arising from this that you want to be sure about? And in the spirit of being sure, Sarah or Karen, can I just turn back to you and just say, what exactly is it that you are asking board to approve rather than note? And then we can just articulate that properly. Take a moment if you need to, but let's make sure that we record that correctly and the directors know exactly what we're being asked to. I read it as appendices 2 to 4, but it may be more than that. So, Sarah, what's exactly the ask of the board, please, in terms of approval?
Yeah, so I think if we go back to slide 2, that really keeps that really has the main things that that the board are just happy to approve, that they have accepted the things that have been presented to you. I don't think it's requiring any particular sign off as such. It's just that the process is that things go through board as a final. You are cited on things rather than anything else. So I think that's the main thing, and I've listed the ones that are relevant to this.
You did,
to this particular submission.
You did in the slide. No, Sarah, it's always right that I just take a pause and make sure, do we understand exactly what we're being asked to approve? And it's about sight then, isn't it? It's about insight and knowledge of the data. Yeah. Okay. Thanks very much, colleagues. Are we all content to have noted and indeed to have approved as asked? And that allows Sarah and Karen, I think, as well, to take it forward, doesn't it? And get sign off and move on with this work. Yeah. Are we all clear as to what's being asked, and are we all clear as to the data that's been provided and no questions arising? Great stuff. As ever, Sarah, thank you very much for joining us, and we look forward to seeing you on Tuesday. I'll be there.
Thank you. Yep. See you soon.
Great stuff. Thank you very much, Sarah. Yeah.
Bye.
Thanks, colleagues. That's really helpful. And again, it's a lot to take in, isn't it? And it's helpful that Karen and Sarah just point us in the right direction as to what we may wish to consider. Really pleased to hear Quality and Patient Safety Academies work on those areas as well. Thank you, everybody. Okay, shall we turn it again back to Karen and just ask whether there's anything from our COVID-19 vaccination programme. It's a verbal item, so it's an opportunity for Karen to bring us right up to date with anything she wishes to. As local lead. So, Karen, please.
Thanks, Chair. And I'm sure Pat will chip in at the end with any staff updates. So we are in the process of closing down what is the winter programme. We expect that to end over the next few weeks. When you look regionally, vaccine take-up has dropped dramatically across all areas of the region. Interestingly, though, we're now doing more than any other part of the region on a weekly basis. So it's small numbers still, but it's as if we've just carried on picking up quite big chunks. And the first week after January, we actually delivered about 1,500 vaccines, where other partners were doing 200 or 300. Wow. And I think that's directly related to some of the work we did directly with, I think it was PCNs 4, 5 and 6 from memory. Where we did some targeted work. We've opened up pop-ups in Ostlers, in Kirkgate. The pharmacies are doing more pop-ups as well. So really targeting. The problem is we're only getting really small numbers at some of these, so maybe 5 or 10 people per session. And it's really hard to maintain that. So we've got a meeting in the next couple of weeks where we're going to talk about the decommissioning of what is existing at the moment and how we move to more of a business as usual. Now, I'm conscious, I think I've said that every 6 months for the last 2 years. It's like a plea, let's move to business as usual, not me. So a paper's being developed that will go to the Place Leadership Executive to how we can make that happen. And we're not expecting to have another campaign until the autumn, unless there is a significant surge and there's a national directive to do that. And that's the same for both flu. Well, flu's only annual anyway, but that sort of update and the numbers covers off both flu and COVID. And we've carried on a very similar pattern, which is our inner city areas, our higher main population areas are the ones where we've got the least uptake of vaccine. But we do try and do additional stuff to go into these areas, whether it be, you know, the Roman Catholic churches in some of the Eastern European areas, working with the mosques, etc.
Yeah.
So that's the update really. So still small numbers, still making some progress. We'd like to do more, but we're probably nearing the end of this campaign now.
Thanks very much, Karen, and thank you to colleagues for making it seems to me, easy for staff and working colleagues within the Trust to be able to access vaccines. The communications regarding that's very clear, and I know many of us have taken that up by getting into the concourse whenever we could, so I'm grateful for that. Pat, I guess it's on this point, but shall I bring you in, please, for how we're doing internally?
Yeah, sure. So in terms of our staffing position, it pretty much mirrors what Karen has said around the sort of community vaccination uptake and campaign. So the most sort of up-to-date data which came through nationally yesterday shows us as having 44.5% of our staff have had a booster, and that compares to a national figure of 50.2%. I think that we continue with our offer, and we sort of continue with sort of both clinics, concourse, mobiles, and we are still picking up some people, but it is small numbers. We're doing slightly better on flu. Our uptake on flu is up to 49.1%, and we are finding that people are still more likely to take up flu than the COVID vaccination. So it has been, I would say, hard work, very hard work this year in terms of getting the workforce vaccinated. But it hasn't been without a lot of effort and a lot of sort of mobilisation. And we are, to be honest, fairly consistent across Bradford Place in terms for uptake.
Yeah. Thanks very much, Pat. That's extremely helpful. I'll pause for a second to see if there's any questions of either Karen or Pat. Pat, may I ask you, do you have a feel for how many of our colleagues have never had a vaccination? Have we got an idea in terms of the percentage or proportion of all our staff, even roughly?
To be honest, Max, I'd have no idea on that. I don't know if Karen could, but no, it's not something I could guess at, really. Right.
Are you kind of in the same position, Karen? We're not sure about that. Okay. Okay. Right. Karen, I guess I was wondering whether we'd taken a particular position on unvaccinated staff in terms of clinical colleagues as to access to clinical areas, etc.
No, we've not.
That dropped into, yeah. I remember that being discussed a long time ago.
Yeah, so there was they were talking about mandating vaccines for all health and social care staff. They did it in social care. It was a bit of a disaster. And actually we've seen the rebound of that, where social care or care home staff, sorry, just point blank refusing vaccines because they felt press ganged into it last time. But we've not taken any additional restrictions.
Okay, we support personal choice. Yeah. Okay, thank you, Karen. Thanks very much. Yeah. Helpful update. Everybody content to note that? Yeah, that's great. Thanks very much indeed, everyone. I'm not sure if Tracy has joined us yet. And I imagine, Ray, you would prefer Tracy to be with us when we took the research activity paper.
Well, yes and no, Max. I did wonder. I wasn't expecting Tracy. I phoned her this morning when I noticed her name there, and she wasn't actually expecting to be joining. So so I think that's probably crept in error. But
no, that's absolutely fine. Well, look, if she joins, she's most welcome, of course. But we have the really helpful report. They're very well put together. I think this has been a good move on our part to bring research as a standing item at board. It's very helpful. Ray, colleagues will have read the report. Is there anything in particular you would wish to bring to our attention from that, please?
No, not specifically, Max. I think it's always a good read, as you say. It's quite a visual document, easy to read document. I think a couple of things just to mention outside of this, really. So I think the board was cited on the new research strategy draft of, I think, before Christmas, back end of last year. Final touches are being put to that now, ready for its imminent launch to the wider public. As you remember, that was quite closely aligned this time, probably for the first time actually to the wider trust strategy. So I think that's a real positive move to bring the research colleagues and the wider trust together a little bit more. Work around the City of Research and our place-based research offering, so Research as One, is continuing to be developed. And I don't know if you're aware, so I think the next board development session, which is in February, I think there will be a focus on research in that, and I discussed that with John, what we might talk about there. So John is going to, John Ratnat is going to come along and talk to the board at the next board development session in February.
Excellent. Very good, very good. Yeah, compliments to who puts that together, Ray? Who authors the report? Is it the research team themselves?
Yeah, I mean,
yeah.
So Tracy Watson coordinates, yeah, but the different research teams will do their bits, and Tracy will bring it all together in one document.
Thanks. Yeah, it's great. It's very well put together, and perhaps in the spirit of what Janet was talking about, there's some things to be proud of there, isn't there? There's a lot of good news in terms of us genuinely trying to understand things. Okay. I'll open for any questions, thoughts, comments on this. Mohammed, please do come in. You got an awkward one there, Mohammed, with the mute. Well, I'll go to Paul, Mohammed. Now we'll come back to you. I will come back to you. Yeah. So, Paul, would you like to come in, please?
Yeah, thanks, Max. And I just wanted to make the board aware of another development and opportunity which colleagues across at BIHR and more widely are actively engaged in. Again, I think I've picked this up just before Christmas, and apologies, we've moved from 3-letter acronyms to 5-letter acronyms now. So there's a thing called a sub-national secure data environment. It's a topic that does actually probably bear more elaboration, and I may well pick up with Ray and John about whether the February board session is an appropriate slot for 5 or 10 minutes in respect to this. But just in terms of a very high level summary, there was a development a number of years back, colleagues might be aware about, called the Yorkshire and Humber Care Record, and it was one of nationally supported investments that were around direct care and more access to information at the point of care, regardless of source. Immensely complicated, and the horrible word interoperability has to be mentioned in this context, and it's a journey, not a destination, to use what that in principle was interested in doing additionally was understanding the potency of data when it came to research and life sciences, but it never really secured an element of budget and investment and focus to that effect. A couple of years on now, the relevant bit of NHS England has re-engaged across the country and said there is money available to proliferate these secure data environments. And I guess part of the branding to say subnational is to make sure that no one has any concerns about the extent to which there's some big brother entity sitting behind all of this, sucking it all up into one picture across the nation. And actually, if you use, again, apologies for the jargon, but phrases like diameters of trust, we are much more comfortable as a community and as individuals with understanding the use of our data when it comes to people and professionals that we are familiar with, rather than to this abstract concept called the government. So long story short, and at very late notice, we, on behalf of the 3 ICSs across Yorkshire, Bradford Teaching Hospital, for all of the reasons that the pedigree of BIHR would speak to us being a very legitimate anchor tenant for this proposal, submitted a proposal to national colleagues towards the end of November. John Wright, Tom Lawton, myself and a range of others actively involved in that. We secured an amount of non-recurrent revenue to come forward with an outlined business case and a full business case, again on incredibly short time scales. At the time, the national body announced 4 sites that they wanted to crack on and get on and do something, Manchester, London and 2 others, and then the second wave includes Yorkshire effectively. The work has gone on to begin to elaborate and develop that business case. Matthew and colleagues from the finance team and more broadly are also engaged in that work, but it's just to flag under this sort of topic area just how significant that investment opportunity could prove to be, because the sums of money available are up to £10 million over subsequent years. It's a richly complicated undertaking. We have many of the right people involved. There is ICS visibility across South Yorkshire, North Yorkshire and Humber and West Yorkshire. And it would be inappropriate for me to claim credit more than just me nudging and supporting that piece of work as we speak. But the board will have to be appraised of it pretty quickly in relation to its next stage, because there's an OBC due for mid-February and then an FBC due by the end of March. But yeah, as I say, it's a genuine opportunity, and I have engaged with Tracy and other colleagues across BIHR in its conception, and would imagine and hope that further iterations of this report going forward are able to announce the success of that and what the plans are to be. But I appreciate the board will want more detail before we become the signatories of something of that significance and import going forward.
Yeah. That's a really helpful brief. Thank you very much indeed, Paul. I hope that can come off. I'm absolutely committed to that idea of research and understanding. So let's hope it happens. Thank you. Thank you very much, Paul. Yeah. Colleagues, were there any further queries? I know Mohammed was trying to get in, and Ray would like to, but Mohammed, would you like to I can tell straight away your mic's off, so you're going to work.
Thanks. Sorry, I don't know what was going on there. Technical gremlins, I had to restart the machine. But I've caught Paul. I caught what you were saying there, and most of it. And actually, my comment was going to be linked to that. Really, I went for a silly run with Tom a couple of weeks ago, and he was filling me in on this in part. And we were thinking about how do we draw the connections between the work in the Improvement Academy, all this research work that Tom and colleagues and Vishal and others are doing, and the work that's visible to us as a board, and particularly at the Quality and Patient Safety Academy. And I wanted to kind of just tease that out, but actually you've answered a lot of that, Paul, so thank you for doing that. But I'm really keen to draw those connections between the Improvement Academy, which is the data bit that Tom's working on, and the work that we do in the Quality and Patient Safety Academy, because I hadn't connected those dots before, and I'm really keen to do that.
Thanks very much, Mohammed. Yeah, there's a fun comment from one of your colleagues just asking whether is it in between breaths you have those conversations.
Up the hills.
Yeah, definitely, yes, yeah. But no, a point really well made, Mohammed. That sort of insight is important to us, isn't it? that's how we move forward and modernise and become outstanding. So it's great. Yeah, thank you. And Ray, please do come in.
Yeah, just to add to that, Max. So I've been in conversation with Tom actually this week, and Tom is happy to come and talk to us in an appropriate forum. So whether that's through the Quality and Patient Safety Academy or to the board, to talk a little bit more about the secure data environment, or the longer description of that Paul talked about before. There's also a piece of research which is gone off for publication, which is probably worth having a talk about at some point, and Tom has offered to talk through that as well, because he's been involved with it, and that's an evaluation around the command centre, which is I won't go into it in detail now, but it's not a published document yet, but there's a lot of really promising stuff that has come out of that. So Tom's offered to come and talk about those two things together, which I think would probably be of interest. And if I can be slightly cheeky whilst I've just got the mic, Max, if that's okay, just whilst talking about quality things and outstanding and things that we're doing in the trust. There's no real obvious section for it, but I think it would be good to bring the board's attention just to the fact that we've launched the second robot this week. Yes. So as you'll know, we've had a program for probably about 10 years now using robotic surgery for particularly prostate surgery, and then extending into other types of urological surgery, mainly cancer, but bladder surgery and kidney surgery as well. That has branched into head and neck surgery, ENT surgery, and now with the second robot, we're planning to extend that into other forms of cancer surgery. So this week starting, we're going to be doing our very first robotic procedure for somebody with a colorectal cancer, and we hope to move into gynecology cancer surgery as well in the very near future. So really exciting times. We're one of the few organisations really in the area certainly to have two robots. It's a big investment, and I think really puts Bradford on the map. There's been, since a sort of press release, been a lot of interest from national media, so BBC and ITV. So we're just looking to plan something with them. But I think it's really good news for Bradford, and as I said, I think it's really going to put us on the map at the forefront of new surgical techniques. I just thought it's probably worth sharing that with colleagues on the board.
Of course it is. I can see so many nods around the virtual table, and delighted to note that. Thanks very much, Ray. And of course, we wish the team very well in launching that second robot, and indeed for the care of our patients who are going to be undertaking surgery led by that. So yeah, using that, of course, rather than led by that. So great stuff. Thank you very much indeed, Ray, for bringing that to our attention. Colleagues, terrific to let's embrace research. Your current trust chair actually chairs the Yorkshire and Humber Applied Research Collaboration currently, so we have some influence there. And of course, we mentioned John and Tom, didn't we, a great deal in that piece, and we know how wonderfully innovative and how well thought of they are. So this is good stuff. This takes us really at the forefront of so many things. A great report, and we've got some good people working in that area, and we can have some influence. So let's embrace that. Thank you very much. We're asked to note the research activity. I'm delighted to see that as a standing item. That says a lot about us. Okay. Thanks, everybody. That's quality and patient safety issues. Again, of course, sometimes we can't always get everything dealt with in the confines of a board meeting. If there's anything to be raised, of course, I know that Cameron and Ray will happily deal with any further queries that might have arisen. And thanks again to the chairs for their reports. In that spirit, shall we move to people and turn to Karen, who has again submitted the report from the chair of the People Academy. But again, an opportunity, Karen, please, for you to bring to our attention anything you think is worth steering us towards, please.
Thanks, Max. So the Academy was held at the end of November. And I think despite the pressures of winter, industrial action, cost of living crisis, and everything else that people have got on their plates right now, it's mostly an improving picture on people. So green shoots for sure. the Governor's rightly raised a question around junior doctor working hours previously, and we gave quite a lengthy response, but we welcomed Dr. Sudeepthi Kakara, who is the consultant obstetrician and gynaecologist, to discuss the obs and gynae doctor concerns that were raised through the GMC training survey. So we spent a decent amount of time talking about the report. It was published back in May, and the response rate was very strong. Issues raised related to rota design, the ability to take study leave, workload, lack of consultant-led antenatal ward rounds of high-risk patients, operating lists and training. And the board, the academy, were reassured around the actions taken to address those issues. So such as rota expansion, recruitment of specialty doctors, further recruitment to add some more resilience to that rota, and ongoing capacity and demand planning. And Dr. Kakara did reiterate that junior doctors weren't allocated places based on how busy a trust was, but on what was necessary for them to undergo their placement for the benefit of the training. So that was a great session. We also had a very thorough update on maternity incentive scheme year 4, safety action for neonatal staffing, which I don't need to go into because Sarah has already done that. But yet again, the papers did come to the academy. We had a good conversation, and assurance was provided at the time of the meeting that there were no staffing issues within the neonatal unit. The session was very focused on assurance. So we did review the People Academy dashboard. There isn't any change to the rating to be one of the best NHS employers, prioritising the health and wellbeing of our people and embracing equality, diversity and inclusion. We did see a slight drop in contacts with the advocacy service over a 6-month period, and 58% of those that had contacted the service have seen their issues resolved informally, which is good news. The number of formal bullying and harassment cases is a lot lower than pre-pandemic, and of the 8 cases completed during that 6-month period, 90% of those outcomes were no case to answer. So Pat and the team are exploring that further to understand why they get raised. 4 people made contact with the mediation service during the last 6 months as well. So whilst we've seen drops in all of those areas, we have seen a slight increase in freedom to speak up concerns. Most of those were resolved informally. Very few were received anonymously, which again is really good in terms of the trust, and certainly trust in the process. And there were no particular themes to report either. Non-medical appraisal rate, 75% for October, has been now for the last 3 months as well, and a slight increase on the previous month for compliance against core mandatory training. So some good news there. Even better, turnover has reduced very slightly again, so now standing at 12.69 for October. And we saw a 1% increase in female workforce at 8A+. A 1% decrease at band 67, so that moves those groups close to proportionate representation. A very small increase overall in ethnic representation in senior management over the previous 6 months, but the Trust isn't currently expected to meet its target of having a senior workforce reflective of the local population by 2025. So I think we need to do some work around that. Proportion of ethnic staff in the overall workforce has increased to 36.96, and you might remember that the target was 35%. So delighted to report that we have a workforce representative of the local population. And the rolling 12-month sickness absence rate at the end of October was 7.15, so that is steadily decreasing as well. National data indicated that 36.2% of Trust staff had received the flu vaccination too. We did review the risks. There are 9 in total relating to the People Academy. Those risks relate to haematology and the long-term sickness of a specialty lead, community maternity team not wearing lone worker devices, consultant vacancies in oncology, rapid increase in paediatric attendance in ED, and then staffing shortages compromising children's community care, qualified nurse ward staffing levels, and safe staffing in unplanned and planned care and maternity industrial action as maternity. And then we had we've created a new risk relating to industrial action. So the Academy sought and took assurance around all of those key risks that they've been identified and reported to the Academy and were being managed and mitigated appropriately as well. And we did a quick review of the work plan. We made some changes. So the frequency of the Health and Safety Committee updates has been moved from quarterly to bi-monthly. We had a thorough update on nursing and midwifery staffing review, and that will now be shared at every meeting. And nursing and midwifery board assurance framework will continue to come to the People Academy every 6 months. We did some revision of looking after our people terms of reference and approved those as well. Pat gave a great update on the industrial action planning and winter planning as well. And we did go through the strategic nursing and midwifery staffing review biannual report. I know we've had a quick chat about that and we'll come on to it. Very much focused on acuity and dependency, and received a very detailed overview and a very robust overview of every ward and the plans for staffing the winter period by Karen and her team. So I'll leave it there, Max.
Thanks very much indeed, Karen. That's extremely helpful. And Karen, you and I know as non-executive leads for Freedom to Speak Up, don't we, that there's been some investment in maternity and the implementation of a couple of guardians in that area. So I think that's very pleasing given the pressures that our maternity colleagues are under. And Karen, I think you've also pointed out that the item at paper 17, nurse staffing review, was indeed discussed in detail at
Absolutely.
People Academy. That's really helpful.
Yeah.
Thank you very much indeed, Karen. Shall I pause for a moment and see whether anything arises from Karen's leadership of that academy? Is there anything anybody would wish to raise, query, question or comment? Pat, please do come in.
I just thought it was worth sharing some good news with the board. So we were advised last week that nationally they were going to fund People Promise exemplar sites for a second year. We're really pleased about that, because that means we can obviously extend Carly Wilson in the People Promise manager role. And I think Carly's been doing some great work, which is starting to sort of show some, improvements in terms, particularly around employee experience and retention. So I'm really, really pleased about that.
That's very good news, Pat. Thank you. And Carly did a great job of briefing non-exec directors in an informal session, and we were all absolutely taken in by her and entirely supportive of what was going on. Great to hear it's going on for another year. We wondered what we're going to do without this. So that's good news. Yeah. Thank you, Pat. I'm glad you picked up on that. Thank you. Were there any other questions for Karen in particular, please? Again, of course, Karen's here with us if anything arises during the course of the meeting. Okay, that's great. So shall we note the Strategic Equality and Diversity Council update? Obviously, in Mel's absence, I'll maybe turn to John in the position of Chief Exec and just ask whether there's anything he would wish to raise from that. But otherwise, of course, we do have the report, don't we? Yeah. John,
thank you for that,
please.
Chair. So yes, as it happens, I attend this meeting as well as Mel. So
thank you.
You've got the written report there. It meets once a quarter, the network, and in the December meeting, they focused on the different staff networks. These are staff-led groups, and on the development of an equality, diversity and inclusion strategy. So for the networks, there's a summary in the paper. I won't read through it all here, but our three main networks, the Resin network, the LGBT plus network, and the Enable network. And then Kez Hayat, our lead on equality and diversity, gave a presentation on the development of a strategy for equality, diversity and inclusion. And if you've been able to read this paper, you'll see that he's hoping to bring that to board next time round in March for sign off from the board. So there's work ongoing on that at the moment, and Kez is hoping to bring it to the board in March. I'll leave it there for any questions or comments.
Thank you very much indeed, John. Of course, the ask of board is that we note the updates and the helpful context that John's provided, and we continue to support the work of that Equality and Diversity Council. Does anybody have any comments they would wish to be noted, please? Are we content to note and thank the work of the council members for what they're doing. Yeah, that's great. Okay, thank you everybody. And we'll move to item 17, please, which is an opportunity for Karen to bring to our attention the report in relation to establishment reviews of nursing and midwifery. And there are 5 recommendations, colleagues, in that. May I quickly remind you of what they are? We need to be assured of the process undertaken in the review. The Board of Directors asked to support the recommendations of the Chief Nurse and Executive Management Team for the 6-monthly Strategic Nurse Staffing Review. The recommendations will come into effect from the 1st of April, and budgets and rostering system will reflect those. This is number 4 of 5 exclusions to this proposal where there's an agreement already in place to support winter preparedness and funding agreed. And then 5th of 5, asked to note that where there's a change in service delivery, the staffing implications will be presented as part of a business case from the CSU with chief nursing oversight of the recommendations related to staffing. I wanted to do that just to orientate us as directors to what the point of this paper is. But of course, we'll turn to Karen and ask Karen to bring to our attention what she would wish to steer us towards. Karen, please.
Thank you, Chair. So if we can go to Appendix 1, which is a PowerPoint presentation, and that neatly summarises the 6-monthly Jenga or whatever puzzle we call it that we do to understand strategic nurse and midwifery staffing. So I won't talk about the process that we go through because Board are well appraised of that. But I do need to bring Board's attention to a few bits just to make things a bit more sensible. So if we can go to the next slide, please. So we focused on 2 areas, acuity and dependency, and also business case development. So there are a number of business cases that I will list in a bit that describe where we're looking at doing those developments, but they will be going into the planning process as we have and under our SFIs and look through that in the rounds with everything else. Next slide, please. So this is an interesting one, and there's some interesting figures on this. And this and the next slide, when you look at them together, tell a tale. So this is, if you look at September the 10th, that was our sort of bed base at that point. And you can see that at that point, we've got around about 475 non-elective beds, plus additional 34 beds that are elective, paediatric beds, and trying to think what Jeanette, oh, that's the total at the bottom. See, I'm adding up and the total's at the bottom. And when you go right across to January the 9th, that's where we are as of today with extra capacity open and things, including the winter ward. Now, why is that important? So there's a total there of 649 beds. So if you go on to the next slide now, and if we, so this is where we were in before the pandemic, so January 20, and then where we were going to get to in September 21, that was mid-pandemic. So at that time, but we've not got paediatric beds on this slide, that was 30 and 32. We actually had 521, if you take 521 beds open. So if you were to add on the paediatric ones, that would make it about 550, 560. So you can see that we've got considerably more beds open now and more wards open now than we had in either January 20 or in September 21. And that is because of the reconfigurations that we've done, having the pure elective surgical wards, and the refurbishments and the developments that we've looked at and funded throughout. So next slide, please. So I'll go through where we have reviewed and where there is an additional need. So Ward 6, we put an additional Band 5 staff nurse on there on nights. It's an incredibly acute ward. Well, it's both really, so it's rehab and acute, but it's incredibly busy. And the data that we look at would suggest that there is a need to have and continue with that additional registrant support overnight. We also want to support staff, and this is a thing going through the NCOP qualification. So this is enhanced care for older people. So we're looking at any member of staff that is working in those areas, such as Ward 6 stroke or care of the elderly wards, that they're encouraged to look at this. Just to know that Ward 6 is currently open to 34 beds as part of the winter I can't even say that word, as part of winter planning. So we have upped the numbers slightly on there as a result of that as well, but that it will revert back to what we are planning if and when those beds close. The next slide, please. Ward 11. So Ward 11 is a newly established ward. It's currently open as Winter Pressures ward, but will be an ultra green ward. When we plan any ward, they have 1 Band 7 ward manager and 2 Band 6s to support as junior sisters. It helps with progression and cross cover, of course. When we did the initial planning for Ward 11, only 1 Band 6 was put in place. So it's a slight upgrade from a Band 5 post to a Band 6 post on Ward 11. Next slide, please. Ward 16. So Ward 16 is our gastro ward. It is extremely busy, and we're also seeing infusions being done on there as a bit of a day case, running out of chairs. This is something that they've been doing to release and discharge people earlier from a hospital, or even prevent them from being admitted at all. So there's a requirement and a request for an additional registered nurse to support that service. Next slide, please. Ward 17. So Ward 17, sort of, if you go back in time, was probably previously Ward 9. It's a very busy downstream medical ward, and we didn't have any acuity data to set the ward establishment. We just went off that sort of professional judgment, really. We've now got Safecare that supports that we need more people on that ward. The amounts of patients that are being specialed on that ward, you'll be aware that we've had a number of SIs in relation to Ward 17, and we've also seen increases in harms around pressure ulcers, deep tissue injury. So it's not just about staffing. There's work to be done there, and standards are improving on that ward, but there is definitely a need to increase the staffing in that area, and it's to increase healthcare assistance to help with delivering of those cares. Next slide, please. Ward 18 is a request for a housekeeper and HCA cover. So as well as being our ENT ward, it also sees a lot of sort of acute referrals coming up for either ENT reasons, eye reasons, facial issues. So it is a very busy environment, and it's one of those things where we suddenly went, well, they've not got a housekeeper, which sort of explains why it's probably not as tidy as it could be, not as organised as it could be. And it's a bit like, you know, book for the nail, the war was lost. You know, these posts are very, very integral to the team and to delivering good care. So there's a request for some additional resource for Ward 18. Next slide, please. Ward 19 is a similar situation to 17, where we've now got more acuity data, but also more understanding of how that ward is working as a new ward. And what we've been trialling over the last few months is a discharge lounge in this area. So patients that can probably go home later in the afternoon or are waiting for transport can be discharged to an area with healthcare assistance support in a seated area. And that allows us to turn over beds and use beds quicker, freeing up the beds on 2 and 5, because 19 is downstream surgical. So this is a request for support to continue to run the discharge lounge out of that area. Next slide, please. Sound like Chris Whitty today. Ward 28 is our orthopaedic ward. It is now functioning as was. It was one of the, the orthopedics was swapped and changed a lot during the pandemic. We know that people weren't going out during the pandemic. People weren't slipping. They weren't breaking the femurs. We know that they are now. We know that a lot of the time we try and get neck and femur patients to the care of the elderly ward. That's not always possible. And Safecare is telling us that there are increasing numbers of confused patients, elderly patients on that ward. So again, a request for additional HCA resource to allow this to happen, to keep our patients safe. Next slide, please. I talked about NCOP before, and this is something again that we want to do. So we're looking at introducing for our elderly care wards, and this is also really important for retention and training of our staff. You know, if we want people to work for us, we need to be able to give them the expertise to do so and make them feel like they're being invested in. So there's some additional HCA requirement, but very slight. That's what our acuity data is telling us. But also we're going to fund a Band 6 practice educator to make sure they will still deliver care as well, but they will also help staff be developed to take those NCOP qualifications. Next slide, please. Critical care, very slight. Skill mix around a Band 7. That's slight cost, nothing major. Again, that's based on our acuity data and national recommendations for staffing of critical care units. Next slide, please. Respiratory. So this is wards 23 and 27. So we still have an additional respiratory ward open, which is 27. But they do not require the same level of staffing that they required in the past when these areas had people on non-invasive ventilation. So there is a reduction in the requirements of staff in these areas, and that's fully detailed in the reports, and that's safe and in line with what our Safe Care is telling us. Next slide, please. This lists the business cases that are under development, so that these will go through the business planning cycle, because I think it's, you know, I've got an obligation to board to review nurse staffing twice a year from an acuity point of view and a safety point of view, which is what I've done. But it would be remiss of me not to say that there may be other areas that require additional, not just nursing, but other funding for those to function if we choose to do that. Next case, please. Next slide, please. So in summary, and this is where the maths gets really fun. So overall, there's a reduction in cost based on the previous paper of round about 360,000. But, and there's a spreadsheet included in overall, in the last 2 years, there's just been just over 5 million invested in nursing, which sounds like an absolutely huge amount. But that is because we've reconfigured and opened additional wards, and we still have additional COVID wards open as well. So this, there has been some, there was temporary funding for COVID, which is being stopped. This was discussed at execs because even though it is a reduction, it will continue to be a pressure on our budgets and our budgets going forwards. I know Chris and Joe represented Matthew and I at execs just last week, and there were some discussions around how that may be funded in the future, because we know there's definitely more money coming in from the ARF funds. So there's ways that we can look at this. So it will be a pressure, even though it looks like a reduction, if that makes sense. Matthew may want to come in at the end and just clarify that, because it's really confusing and takes a long time to get your head around. It's took several meetings. So full details are available. Next slide, please. And this is the summary of the recommendations that Max helpfully went through at the beginning. So this is my 6-monthly annual staffing report, been done in line with national recommendations. I won't go through and repeat them, but that is what I'm asking board's approval for. Thank you.
Thanks very much indeed, Karen. And of course, the board had asked really, of course, to trust to the chief nurse's judgment here. To some extent, we can't possibly know the detail of every single ward, but we get that data there that helps us see the changes. Karen, may I just check with you? Do the in terms of the methodology for the review? I don't want a full briefing on that, but do the workforce have a say in the way in which you review staffing?
Absolutely. So
yes.
Every ward manager and the matrons meet, they then report to the director of nursing, which is Adele and Sarah. That then gets aggregated to up to me and Joe. If there are any controversial areas, they will meet directly with me and or Joe. we use professional judgment, which isn't necessarily my professional judgment, it's the people on the ground, and we listen to what they're saying. We look at incidents, we look at claims, we look at the acuity data. So every day on the wards, we run a process, it's electronic, based on the e-roster, where it tells us how sick the patients are on the wards. And it does it in two ways. It says how sick they are from a really sick, needing technical registered nursing care. And it also tells us how much they have care needs as well. And that's why we know it's an increase in healthcare assistants or registered nurses that we know, because we collect two types of data, really, or lots of pieces of data. All that is then triangulated, and we pull that all together.
Yes, Karen, thank you. That succinct description of the methodology, I think, was important for directors who are perhaps not always cited daily on these things to understand. And that's why I think we can take assurance from the professional judgment that at the end of the day perhaps endorses the decisions. Okay, colleagues, we've seen the 5 recommendations. Were there any comments, questions, thoughts before we move to asking to take those? Janet, please do come in.
Thank you very much, Karen. I was just wondering if the review either created more or gave different types of placement opportunities for nurses in training, because that's a huge pressure.
So we introduced that about maybe about 18 months ago, 2 years ago. So as part of the review, we ask how many students they have, and we then look to see is that what they should have? Is it constant with other areas? And so that because we found that some wards maybe had 2 students at any one time, and others might have 6. So everybody has 6 now. We didn't drop down, but we put in a lot of additional student capacity on the back of previous reviews, and it's something we check every time as well.
Thank you. That's really helpful.
Thank you, Janet. Yeah, thank you. And Matthew, please, Mike's with you.
Yeah, thanks. Just to pick up on Karen's comments earlier around the nature of the funding that we've had in place for a number of years to support COVID. So when we look at, there's a huge amount of information, isn't there, here to support this, and one of the appendices highlights that the closure or the reclassification of some of the respiratory beds releases around about £1.4 million worth of funding associated with COVID, but noting that we're going to lose in excess of £7 million worth of income from the centre to support COVID, but coming back in, and it's highlighted in all of the slides, is around about £1 million worth of additional cost to support the SAFER and the acuity, the workload. So it was just highlighting that, albeit the presentation highlights a net position, we do actually, we're probably exposed to the tune of around about £1 million extra from a funding perspective, and it's something we need to consider when we're establishing the financial plan for 23-24. Not questioning the tried and tested methodology at all, Max, that you've already highlighted, but we just need to be, the board just need to be highlighted that there's probably about £1 million extra going in that's not supported by funding from a financial consideration for next financial year. That we have planned for, Matthew. It will have to be built into our financial planning assumptions. Yeah. Yes, thank you. That's actually really helpful context. Of course, we should know that. So thank you very much for that additional detail. It's extremely helpful. Okay, colleagues, so we've got the 5 recommendations. I'll not read them through again as well, but can I assume that you have those in front of you, you've checked them through, you've had the chance to ask any questions, queries, or additional information. May I ask whether we approve of those recommendations? Yeah. Without objection. That's great. Okay, so that's all approved. A very helpful briefing. Thank you, Karen, and thanks for the succinct description and methodology there, which I think just provides assurance for those of us that don't see that every day. So that's extremely helpful. Thank you very much indeed. Okay. Before I close, shall I just check were there any other people issues that may have arisen in our conversations that anybody wanted to endorse, comment, question? No. That's absolutely fine. Okay, so we're at 12:51 on my computer clock. So can I suggest we take a break and give the chance to, for people to grab a drink and maybe a sandwich and things? Would 20 minutes feel appropriate? Could we say that we'd get back in here at 1:10 I do realise if people have to then therefore rejoin with a sandwich at the side, that's absolutely appropriate. But let's do that. Let's see if we can do this in 20 minutes. So 12:52, I'm going to say 13:10 then for us coming back, yeah?
Okay. Thanks, everybody. Really good discussions on